Well, the chap next to you, Professor Marshall Lightowlers, I actually thought he was going to turn up today in overalls, because if you have a look at that little NHMRC document that we've been given, there's a picture of him in overalls, the immunologist in overalls, because I always thought immunologists had white coats, but you can see how sartorially splendid the professor is this morning. But Marshall, you say that you were attracted to an idea of doing some work that not only was cutting edge but was practical. The idea of you in overalls seems to be a very practical image. Can you talk a little bit about why that's important to you?
Yeah, I've been very keen to see if I could manage to follow through from the rationalisation from doing the work in the beginning through to actually achieving a practical outcome. And very few scientists are lucky enough to manage to do that within a research career. And through luck and very hard work by all the slaves that a scientist has working for them, we've been lucky enough to get to the point where we're now beginning to roll out the use of new vaccines that we've made in Australia to prevent parasitic diseases of people in very, very poor parts of the world. And so I do spend most of my life not with a clean shirt and a bow tie, but with a pair of overalls, working with sheep and pigs and working in remote parts of Cameroon and other parts of Africa and remote parts of South America. But I think that we've got to the point now where we can look to the future and really see a likelihood that the work that we've done with NHMRC support, for which I'm extremely grateful, will actually bear fruit and reduce the burden of these diseases to the poor people.
And why are parasites such wily opponents for you? And do you see them as opponents? Is it sort of a fight to the death of them?
Well, if it's a fight to the death, they're likely to win, except for perhaps the particular ones that I work on. So that we've been lucky in the small group of parasites that I work on in finding a vulnerable niche that we can exploit. But eukaryotic parasites belong to the same group of organisms that we do, and their genetic complexity is as complex as we are. And so they have incredibly sophisticated ways of avoiding being killed by our immune responses. And it's for that reason that there's never ever been a vaccine against any human parasitic disease, even though there are many vaccines against bacterial and viral diseases. The parasites, the worms and the parasites that cause, for example, malaria, have been a really difficult challenge for us.
Well, Professor Richard Harding, who's next to me, and I'll ask you a question and I'll hand you... Oh, no. You've been researching how a baby's lungs functions independently at that moment of birth. And in your profile for 10 of the Best, you talk about the important role of collaboration, and the Minister mentioned. What are the mysteries between that moment of the baby being in and the baby being out? I mean, what turns you on about the mysteries of that moment?
Well, it's the mystery of it is that it happens so smoothly in the majority of cases. It's an incredibly complex change of physiological events that happens around the time of our birth. And it is truly miraculous that most of us come out relatively unscathed. We're interested in the approximately 10% of babies who come out too early through no fault of their own and no fault of their mothers. And we don't really currently understand why so many, about between 8 and 18%, depending on regions, of babies are born too soon, and that can be as early as 24 weeks, which is a little more than halfway through the normal gestational period of 40 weeks. So these little babies have to make an enormous and rapid transition if they're to survive, and of course in the past most of them died. It's only in the last 20 or 30 years or so that most preterm babies have a good chance of survival and a good chance of living to be healthy, competent adults and have a normal life, although of course there are long-term risks. So, in answer to your question, I'm a basic physiologist. I got into this area of fetal and newborn research more or less by accident when I was a postdoctoral student candidate, and it fascinated me so much that I've stayed in it right up until the present time.
What was the accident?
Oh, the accident was an offer of a job when I was in Melbourne, an offer of a job in Oxford from a former, well, it wasn't exactly a colleague, someone who knew of me through someone else, and I got an invitation to go to Oxford and work in this, at that time, was a prominent research centre for fetal physiology, fetal development. So I had particular skills that they wanted, so I ended up there never thinking that I would become interested in fetal lung development. So it was my interest in fetal lung development. I actually shared a laboratory in Oxford with a doctor who specialised in newborn medicine called Colin Morley, and he was interested in something that I knew almost nothing about at the time, which was called surfactant. And I thought, why is this man so interested in surfactant? Well, it turns out that the surfactant, the lack of it, is why most premature babies die, or used to die. And it presents, the lack of surfactant presents the biggest problem. Now, for the students, surfactant is like a soap or a detergent that lines our lungs, and we can't live without it, because if we don't have surfactant in our lungs collapse and we can't open them. So unfortunately, premature babies haven't developed to the stage where the surfactant is mature. So...
and where does the collaboration come in? Why does it take so many people?
Well, because in our group where we have lots of different expertises, but what's really made the difference in terms of this project is that we work with two very prominent neonatologists. Neonatologists are the medical specialists who look after sick newborn babies, and most of the babies that they deal with are in fact premature or very premature babies who are born anything between 24 weeks to 37 weeks. And the beauty of my situation now, and during this having the program grant that we've got this award for, was that we're working right across the spectrum, from molecular biologists who are interested in how molecules work and genes work, right through to doctors who are working with sick babies who can put our ideas into practice. And in fact, that has happened during the course of our project. And what delights me about this, the work that we've been doing, that we basic scientists have been able to make a difference in the nursery where these very sick premature babies are being monitored.
Thank you. Professor Dina LoGiudice, you're a medical researcher too, and your research is different again. You travel Australia to remote communities. You're interested in the different ways different cultures analyse whether they're older people are suffering from dementia, for example.
Yes.
And it's intriguing to think that some of the things that might imply somebody's suffering from dementia in an urban environment like Sydney may not necessarily be the same things you'd look for remotely. Can you speak a bit about what your research has been?
Yes, thank you. My research with many other people started about 10 years ago when we looked at, as you're probably aware, we're hearing more and more about the problem of dementia in older people, but there was very little information about older Aboriginal people living in communities. And so this research started trying to address that problem because in different cultures their understanding of dementia might be different. So, for instance, in Aboriginal communities, sometimes they say that it's due to a weak spirit rather than conditions that are happening in the brain. So one of the first things we did was to try and develop some particular questions that were relevant to older people living in different communities. So I've had this great job going around to different communities and meeting some of the older Aboriginal people and asking them how they view some of the aspects around memory and thinking and how the best way is to test that. And then from that we determined that people in the Aboriginal communities actually have quite a high rate of dementia. So it was thought to be about 4 to 5 times more than non-Aboriginal people. So from that, we decided, and the reason that we're part of this program today is that we went back to the communities and said, and asked people there, and in this particular community in Luma, which is about 300 kilometres south of Broome, we asked people there, the community members, how they would like their older people with dementia to be looked after. And so this program was very much built within the community, and we employed people in the community to look after their older people. So really it was a partnership trying to find out what works best in that setting, and also trying to teach people about dementia and the best way so that they could care for their own older people.
So what would be the difference, like, if you're trying to look at memory in a person in Sydney and a person in remote Australia? How would you, what would you ask them that would be different?
I see. So yes, the first time we went up, we asked lots of linguists and lots of people what we did. So what we do is we actually show a cup, a pannikin, a box of matches and a comb, and we ask people to name those and then hide them. And so other ways that you test memories by showing different pictures and asking them to remember them. So we just tried to make the questions very relevant. Another question we asked, which sounds a bit silly, is to ask people how many animals that they hunt, because it's the tradition in that area. So how many animals they hunt, and so they have to name how many animals within a minute. So it's really trying to make it much more relevant, because aspects such as day and time mightn't be relevant to a lot of the older people. And you have to remember that these people, English is their 3rd or 4th language, so they speak very many different languages. So it's really trying to adapt it so that when we asked questions, that it was relevant to them.
Well, just next to you, Professor Richard Osborne, you're an epidemiologist, a different kind of medical researcher. You're interested in the way health and functions in populations. What was your path to it? Were you interested in mathematics? Is that how you got there?
No, not really. My main motivation to do medical research was to help people, really. It was really quite simple. And I found myself in a situation where there was only 1 or 2 people in front of me. I thought, that's just not acceptable. I think there's something about me which I can help more people at once.
You mean 1 or 2 people in front of you as a doctor?
Well, no, as a natural therapist, a massage therapist,
right,
doing lifestyle counselling. And I thought, well, this seems to be a waste of something about my talents. And so epidemiology is the science of fantastic experimental design, how to really find out whether the answer is correct or not when you do an experiment. And then to survey people, to see precisely how many people have this condition or that condition. Then to find out precisely how many people have benefited from this intervention. And my work was really about, a lot of it's been about observing things. And in research, we have to observe so many things so carefully to be able to see what the problem is. And I think I've become so thrilled about the opportunities for innovation, discovering and doing things that no one has ever done before by simply being out there. So I don't have a laboratory at all. My laboratory, like Dina, is people's homes, and it's their lives, their environments, what changes for them on a daily basis or over years. So that's my environment. So in seeing in a hospital setting that people, hip and knee, everyone would know arthritis, it hurts many joints, and when it gets really bad, you need to have a joint replacement. So we observed in hospitals that, in the public hospitals, that a lot of people might have been waiting for a year or 2 years or 3 years, and their arthritis could be getting worse and worse. They could be losing their jobs, losing their caring roles, the pain could be making them terribly depressed. But the healthcare system wasn't observing them and picking them up. it sounds horrible. We could see that 15 to 20% of people were just rotting at home. And the system wasn't picking them up. Completely unacceptable. So for me, I had to do something about it. So in discussions with the fellowship that I had from the NHMRC, which gave me 5 years to think about things and come up with solutions, we come up with a solution which worked for the surgeons and the physiotherapists and the hospital managers and our state government. And now we have a streamlined process so that best care is given to the right person at the right time. And I have this incredible honour that there's 10,000 people or more per year who are using the model of care that our team developed, of a whole range of experts, is being used. So that people are now getting surgery at the right time so that they can get the benefits and keep their jobs, to keep their caring roles of their elderly partner. All these really cool things. So just by observing, we saw inequities that could be changed, although we didn't know how to do it. And that was really scary because a lot of countries had tried and failed.
But how to go into people and saying, tell me how you're feeling now and what you'd like. I mean, you went and asked the patients, didn't you?
Yeah, we asked the patients, what do you think are the main characteristics of who should have surgery next? Who should be on the operating theatre next, on the table?
Who should be on before you?
That too. So we asked the surgeons and the patients that. And we asked the hospital managers, we asked all kinds of people through the whole pathway in hospitals and got a whole lot of crazy stories and good stories. So we come up with a system which actually agreed with everyone. It was really hard to implement, but the benefits to the patient were so good that it ended up being implemented. And it was a huge range of very senior clinicians and support people who helped us produce such a complex new improvement. So it's all through Victoria. It's a normal part of practice now. It's mostly through South Australia. And it's a really cool thing to have found it so unacceptable and invent a process with other countries had failed, and we invented it through really great collaboration.
Well, Minister, I mean, when you hear that, I mean, as a public policy person who enacts that, I mean, what are your thoughts about projects like that?
I just think it's a wonderful story. I've loved all of these stories because they really show you the range of health and medical research, right from the sort of molecular to the big systems. And I think it shows that if you're interested in science, if you're interested in health, if you're interested in helping your community, whatever particular fascination you have, there's a place for you to exercise that to help find solutions.